Welcome, everyone. I'm Robin Toohey, Vice President, Patient Support at the International Myeloma Foundation. We're happy to have you join us for our Living Well with Myeloma infection prevention and management. This is such a timely topic. I know it's important to each and every one of you, and our goal is to help you learn to obviously live well with myeloma and avoid these challenges that we have in the upcoming season and to give you the information that you need. So tonight, I want to just talk to you before we begin. I do want to share with you some very sad news for those who may not have yet heard. So, Dr. Brian Dury, our beloved co founder of the International Myeloma Foundation and a true giant in the field of myeloma, passed away just 2 days ago. My husband Michael and I have had the privilege of knowing Dr. Dury for 25 years, and during that time, we experienced firsthand his extraordinary care, his brilliance, and his unwavering dedication, not only to us, but to patients and families around the world. He was our North Star, always looking ahead, always guiding us toward a better future, and showing us the path forward with clarity and hope. We extend our condolences to his family and to each of you. His legacy lives on in all of us, and we are committed to carrying forward the IMF mission with compassion and in remembrance of his tireless pursuit of a cure. While we mourn the loss of a great man and co-founder of the IMF, we can also look forward and ahead with the confidence and optimism. With the appointment of Heather Cooper Ortner as our new CEO and president, whose previous tenure as executive vice president of development at the IMF and close work with the staff and Dr. Dury reflected deep understanding of the IMF's mission. Heather is well positioned to build upon the strong foundation laid by our founders and lead us into the future. I'm excited to work with Heather. The entire staff is looking forward to working together with her, and she looks forward to meeting all of you. Many of you know at the IMF, our mission for 35 years has been to improve the quality of life for myeloma patients while working toward prevention and a cure. And that remains our mission. Our vision is beautiful, in my opinion, to realize a world where every myeloma patient can live life to the fullest, unburdened by the disease. Our 4 pillars remain with research, support, education, and advocacy. So now we're going to move right into what you're here for, and it's my absolute pleasure to welcome 2 amazing women in the field of myeloma, Dr. Beth Faiman, who is at Cleveland Clinic, Taussig Cancer Institute, and then Dr. Zahib, who is at Memorial Sloan Kettering Cancer Center in New York. And tonight, they are each going to take turns sharing their wisdom, resources, and information to help us all on this infection prevention topic. We thank our sponsors, as always, for tonight's educational program. And tonight we have AbbVie, GSK, Johnson & Johnson, and Sanofi. I want to remind you how important it is that we do hear from you. And at the close of the meeting tonight, there will be a feedback survey is going to pop up for you. You can take that survey immediately at the end of this program, Or if you don't have time tonight, we're going to email you the same survey shortly after the workshop, and you can take time when it works for you to complete that so we can continue to bring you valuable programs. Tonight, you're on the first of something brand new. We are using closed captioning. And so you can see here, there is a button in the control bar at the bottom of the screen. If you don't see it, click more. There's 3 dots, and then look for the closed captions or show captions, and then click there, and that's going to turn on the subtitles for you to view. And the button, if you want to change it to hide the captions, you can switch back to hide the captions. That would be something good for you to comment on. Let us know how well you liked and how did it work for you utilizing the closed captions. And that was brought to you based on feedback from previous participants at other programs. As a reminder, all of our video replays and slides are available right on myeloma.org. You click on this area here where it says publications and videos, and you scroll over to IMF videos in the middle column there. You click on that, and that's where you'll find the replays. So now it is time to finally introduce you to Dr. Faiman and Dr. Shahid. I invite you to please take it away.
Thank you so much, Robin, for having us today. This is such a timely topic. There is such an overwhelming interest in what you can do as a patient, as a loved one, caregiver, friend, or support system to protect not only you, but others. So what we wanted to do here tonight is share with you a little bit of a background about why patients with multiple myeloma are so at risk for infections, share what kind of infections you're at risk for and what other characteristics are putting you at that risk, and what you can do to protect yourself and your loved ones. So what about the incidence of infections in myeloma? This is a high topic of concern. Patients with myeloma are at least 5 to 7 times greater than the general population of having infections. We'll explain why in a moment. The greatest risk is actually during the first few months of treatment, and then it's what we call bimodal distribution, where it goes higher as you have myeloma living longer. The risk of infections is up to 70% and can be severe at times. We do recommend ongoing antibiotics, antiviral therapies, good hand washing, et cetera, which we'll get into to help minimize your risk of infections. The specific treatments we give have different levels of infections, which will also be discussed as well, which can increase your susceptibility. So again, why are infections so common in myeloma? It's really based on the biology of the disease. Myeloma cells will not only replace the healthy plasma cells, but they are part of your humoral immune system, your basic immune system and ability to fight off infections, and I'll explain that in a moment. The role of the plasma cells, which are specialized immune cells, produce and secrete large amount of antibodies or proteins to fight off specific infections and foreign substances. The treatments we give can lower the normal healthy immune system cells, such as the neutrophils. We see that with certain chemotherapies and cellular therapies as well. So going back to the biology of why these cells put us at an increased risk for infection, and this is kind of the discussion I have with all of my new patients. So in your bone marrow, the plasma cells, which are the most mature B cells in the body's lineage as you develop, make these immunoglobulins that are intended to protect you from getting sick. These are Y-shaped molecules that are anchored by a heavy chain. That's IgG, IgA, IgM, IgD, IgE. And then they have these light chains on top, which are kappa or lambda. Again, these very specialized cells will not only neutralize and eliminate foreign viruses, bacteria, and pathogens, they will recognize and bind to antigens, which we'll discuss a little bit more later. And then they provide immune memory. Once you've had an infection, that will stay in these cells forever. Unfortunately, there's a disruption or a dysfunction in the way that these cells are formed, and so that will cause an increased risk for infections. Now, the next 3 slides are just a few of the common tests that you might see, whether you have smoldering myeloma, newly diagnosed myeloma, or if you've had myeloma for a while. These are some very basic and not all inclusive tests of the immune system function. The first one and very common is the complete blood count. I tell my patients the complete blood count is a window into your bone marrow's ability to make healthy cells. The three main cell lines are the white cells, which primarily fight infection, the hemoglobin that carries oxygen, that's your red cell levels, and the platelets that clot the blood. Now, when you further break down the cells, you have cells called neutrophils, which are really important at clearing away, especially bacterial infections. And after patients have transplant or cellular therapies, many times they'll be neutropenic. We give these therapies to target the B cell plasma cells, and as a result, the lymphocytes will go low. So you see a lot of what we call lymphopenia in your blood counts or low lymphocyte counts. These can be extremely low after cellular therapies or bispecific antibodies, as Dr. Shahid will go into later on. But basically, this complete blood count will give us a really good picture as to how your white cells, red cells, platelet function, and the breakdown of the cells are. Again, low white cells can increase your risk of certain infections, and low lymphocytes can put you at risk for viruses and bacteria. So hypogammaglobulinemia, what is that? Hypo means low, gamma globulins, and anemia blood. So hypogammaglobulinemia. So most patients with multiple myeloma will experience this at one time or another. Maybe it's at diagnosis or based on the biology or disease, but this is an example of a simple blood test that you might see in your charts. The IgGs, IgA, and IgM will routinely be tested by most specialists. You can see this is a patient that went through a cellular therapy and had a low IgG, normal range is 700 to 1600. So this individual was eventually placed on IVIG to enhance their immune system, and Dr. Shahid will go over the importance of IVIG after cellular and bispecific therapy. And what happens is we had what's called immune reconstitution. Eventually, the patient's immune system kicked in, and they were not requiring these IVIG infusions anymore because the cells recovered. Now, I won't go into great detail about this slide, but some of you might see these CD3, CD4, T counts, etc. Basically, this is just one way of looking at how we'll interpret your CD4, CD3, etc. counts for your immune system. So the CD4 count in this patient is 179, and once that level's less than 200, this is a person on a bispecific antibody therapy. We will give them preventative antibiotics. There's one called Bactrim, which it's given different ways in different institutions. Some people do a single strength daily. Some people do a double strength 3 times a week. Sometimes you might have an allergy and be on something called pentamidine, which is inhaled or IV. But at any rate, you might see these come through your MyChart and discuss these results with your primary providers that are managing your care. And Dr. Shahid sees these all the time in her infectious disease clinic, which that's her specialty. She is a fellow of the Infectious Disease Society of America. She's an infectious disease specialist. So again, viral infections, bacterial infections, and fungal infections can happen at any time. But remember, at the very beginning of therapy, it's the highest risk. And later on in the therapy and specific viral therapies, specific therapies such as cellular or bispecifics will increase this risk. This is just a laundry list of certain viral infections that we're being screening you for, especially if you've had cellular therapy. I'll talk in a few moments about the different reasons for risk. Now, at this time, I'd just like to have a pause for discussion with Dr. Shahid, and don't forget to put your comments and questions in the chats. I'd like to hear from you, Dr. Shahid. Why do you think myeloma patients are at an increased risk of treatment-related infections at beginning or later in the treatment course?
Thank you so much, Beth. Thank you for very eloquently sort of starting the story of the patient. And it starts way before they get us. When they are not diagnosed early on, they may be experiencing signs and symptoms of infection. Many times multiple myeloma is diagnosed because of an infection. You know, the textbook where invasive pneumococcal infection is the reason that the people are diagnosed with multiple myeloma. So like you alluded to, the bimodal distribution. The first peak is at the beginning of the therapy, and then there are many factors which are contributing towards the high infection risk. their host factors, meaning what the patient is coming in with because of multiple myeloma. Impaired humoral immunity because of the disease itself, like you said, the immunoglobulins. Impaired cellular immunity. The T cells are dysfunctional when the B cells are not functioning. So that's the high risk. And also the complement system, there's another part of the immune system that is dysfunctional because of the plasma cells not working very well. And then at many times, as you know, that there are comorbidities that we are, patients come with. They can come with renal failure with multiple myeloma. They may have hypertension and diabetes. They increase the risk of infection. Sometimes patients don't even know that they have kidney failure at the time of diagnosis. And then we get them started on the treatment, and early on, we do not know their net state of immune suppression. We don't know where they are. So that's why the early peak. Then they've established care. We've gotten their disease controlled, and then we know what to put preventative measures to take. And then when the disease takes off in the relapse refractory setting, that's the other peak. And that's mostly driven not only from host factors, but because of the disease burden and the therapies they may be on, because they be more potent immunosuppressive therapies. So sort of the story goes like this, and it starts from the beginning, and we continue to follow, and assess the risk at every stage. And the risk component of what is causing changes over time, for sure.
Absolutely. So thank you so much for that background. And I agree, there's just so many different factors. And when you look at maybe the blood tests like the CBC and the immunoglobulins, that's just a piece of the puzzle of what we can measure in the blood. Those biomarkers are not telling the whole story. There are risk factors, as Dr. Shahid alluded to, such as diabetes, which can lead to a dysfunction of the immune cells, chronic inflammation. And we know that patients with high blood sugar levels, especially if they're hospitalized and very, very sick, can do more poorly in terms of infection. We also heard from the doctor that heart, kidney, and liver disease can lead to impaired organ function and a lower immune response. We see a lot of patients with myeloma and rheumatologic disorders. Sometimes they don't even have myeloma. It might be a pre-myeloma monoclonal gammopathy or a smoldering myeloma, but some of the rheumatologic drugs that are used to treat will lower one's immune response as well. And then older age, there's this idea of immune senescence, which the cells stop dividing but keep remaining active, and that can cause an increased risk for infection and illnesses as you age. So here's a table that I put together, and so there are numerous guidelines. Dr. Nupur Raj was a lead author on guidelines in 2022. Dr. Shahid is the lead author of the Transplant Cellular Therapy Guidelines, which is why I'm so excited to have her here tonight, because I cite those guidelines all the time. And then we have National Comprehensive Cancer Network general recommendations. But we can look at one's risk based on the type of treatment they're on, might be higher or lower, or where they're at in the disease, as we heard. Immunomodulatory drugs such as lenalidomide and pomalidomide carry with it a general low risk of infections, mostly that can cause some neutropenia, which is those low neutrophils. You see that on a complete blood count test, and low white count. The proteasome inhibitors such as bortezomib, carfilzomib, ixazomib will also carry a fairly low risk compared to our newer therapies, mostly through neutropenia. There is an increased risk for shingles. So if you're on these therapies, you should be on shingles prevention. Even if you've got the shingles vaccine, those were not studied in patients that were on active anti-myeloma therapy. So we'll still generally recommend you to take acyclovir or valacyclovir, even if you've gotten the shingles vaccine, because we still think that it carries with an increased risk, at least in most of the clinics that I am aware of. The anti-CD38 monoclonal antibodies, those are daratumumab and isatuximab. I call those a moderate risk for infection because you see a higher risk of pneumococcal or pneumonia type infections, a higher risk of viral infections with these patients, especially if you're on long term. We're now seeing patients that have been on these for long term, especially in combination with pomalidomide or lenalidomide, that have an increase of these rare types of diseases you wouldn't see as common, such as cytomegalovirus or CMV. And so we're having to look a little bit more closely at the individuals on these long term. Now, the cellular therapies and bispecific antibodies are high risk, red flag areas where we really need to be more aware. We're moving cellular therapies on earlier on in the treatment, so hopefully they'll have fitter immune system, better T cell function, and not as much of a risk of infections, but that still remains to be seen. And Dr. Shahid will go into great detail in a few moments about what we can do to protect ourselves. So again, the newly diagnosed myeloma patients, and as you heard from Dr. Shahid, we also see increased infections, and I have to honor Dr. Dury. When he put forth the guidelines for diagnosis in 2003, it used to be crabby. So right now, if you're diagnosed with myeloma, it was hypercalcemia, renal insufficiency, anemia, and bone disease, which is crab. But we used to have I for infections. And so early in the 2000s, we would start patients on anti-myeloma treatment if they had recurrent infections. So I called that crabby. In 2006, they took away the I, but I still feel like infections is a presenting symptom, as you heard, for some patients. Some studies actually had suggested giving antibiotics for the first 3 months of therapy. There was a study, it was called the TEAM study, Dr. Drayson was the lead investigator on that. And in some countries, they'll give levofloxacin or moxifloxacin for the first 3 months. It's the standard of care in some institutions. That study didn't meet its primary endpoint after a while, so it's not widely adopted, but there is some evidence that it can decrease the risk of severe infections early on. So protecting yourself with good hand washing, vaccinations. If you don't want to get vaccinations or you can't get vaccinations, I believe in herd immunity, so have a loved one get the vaccine. And we'll talk a little bit about how effective vaccines are in patients with myeloma and at what time point as well. So in maintenance therapy, we think your risk, if you're just induction, you had your first treatment for myeloma, then you have your transplant, and now you're on the maintenance. If you're just on lenalidomide or Revlimid, then you generally have a low risk of infections at that point. You're kind of sailing along, you wash your hands, you avoid people with colds, you get your immunizations, and you're not really on any antiviral or antibiotic prevention. You're just on the Revlimid maintenance. But the newer studies with CAR T-cell, bispecific antibodies, and combination daratumumab will start placing patients at a higher risk for infections on maintenance where they aren't now. This is just a study that I clipped that was recently presented in a paper that talked about this bimodal distribution. And what you're looking at on this slide in the little red bars are the controls. Those are patients that don't have myeloma. And you can see the -12 to -0. That's the year before myeloma was developed. And in this population-based Swedish registry study, they saw that patients started to have a little increased risk for infection. You can see that -2 mark, but then once they were diagnosed with infections from the 0 to 6 month phase in this study, you had a higher risk of infection. Now the cutoff here on this slide is 24 months, but when we talk about the bimodal distribution and the increased risk of infections, you can see patients living 5, 7, 10 years. And if you're interested, you can go look up the study. It's kind of interesting and goes into more detail over different time points as well. So at this time, I'm going to pause and I'm going to let Dr. Shahid drive the discussion as she just talks about the frequently asked questions. And just tell me when to push your slides, Dr. Shahid. I have the clicker.
Thank you, Beth. So moving right into the more novel therapies such as bispecifics and CAR T therapy, as you know, that CAR T therapies has really changed the landscape of treatment for hematological malignancies, specifically multiple myeloma. The patterns of infection among different CAR T therapies, depending on the target mean what is it focusing on, whether it's lymphoma versus myeloma. And for our patient population, it's myeloma here. We can see that they have a higher risk of infection when they compare with CD19, which is the lymphoma population. So we are very careful about the multiple myeloma patient who receive CAR T therapy. And the infection density, as you can see on the right, is higher in the first 30 days. So the first 4 to 6 weeks is where we watch them very closely and put them on appropriate prophylaxis, along with in certain patients, some sort of surveillance to make sure the cytomegalovirus, for example, does not start to reactivate. Early on and later on, sorry, no, that's okay. So if you can see going up to 90 days, it's sort of a story, like what is happening with your immune system. Your immune system is still very weak. You are still at risk of bacterial infection, as you can see in the red. Respiratory viral infection are a high risk for first 90 days for all BCMA CAR T recipients. So you want to be very careful about masking, making sure you're not going in the crowds and you're protecting yourself and your from your community exposures. And then very rarely, not very common, some fungal infections. Because what's happening with the immune system, there is still a net state of immune suppression early on, especially in the first 90 days. The B cells, the T cells are depleted. Some patients get CRS after CAR T therapy, and for that, they get steroids. Those steroids received also increase the risk of infection. So there is a early on higher burden of infection in CAR T therapy patients. Data shows that for CAR T recipients, infections can be associated with poor outcomes. So we do our best as institutions and caregivers that making sure that our patients are protected from the environment and what we can do by putting them in appropriate prophylaxis. Next slide, please. So who is at risk of CAR T therapy infections? As Beth alluded to, some of the many same risk factors also contribute to risk factors after CAR T therapy: older age, presence of low immunoglobulin therapy, how infiltrated your marrow is prior to CAR T, and what kind of cell counts are we seeing if you have low platelets, low hemoglobin, low WBC count, which are persistent, the risk of infection is higher. And obviously, when people are treated with steroids for CRS or have complications related to CAR T, sometimes they can be cytopenias for a longer period of time. We keep them on prophylaxis because this is the high-risk population for infection. Next slide. So what are the common antibiotics that your doctor is going to prescribe? It depends on what's happening with the patient's net state of immune suppression. In the CAR T therapy world, not a lot of patients are put on quinolone for antibacterial prophylaxis. Some centers do it. We do it in the setting when we know that the patient's absolute neutrophil count is going to drop less than 500 for a longer period of time. Most often, you will probably be on acyclovir or valacyclovir prior to starting to CAR T because you're coming with some sort of therapy. But if you're not, then patients are started on acyclovir or valacyclovir. There are certain people who have very dormant Hep B. They had prior exposure. They completely recovered from it. But sometimes the virus is so clever in the setting of immune suppression, it can reactivate. So we test them ahead of time and put them to prevent Hep B from reactivating. And you can find in the literature that there are reports of people reactivating Hep B if they had exposure in the past after CAR T therapy. Antifungals, not so very common, very early, very briefly, very early on in the first 7 to 10 days, only if needed. But the PJP prophylaxis that you might be put on for bispecifics and for CAR T therapy, you would be put on. When we talk about bispecifics, we have another slide. The prophylaxis is similar. Many times quinolones are not given because that depends on your WBC count, and so are the antifungals. But most often, we will put patients on PJP prophylaxis with Bactrim or Dapsone or Mepron or pentamidine and acyclovir or valacyclovir for HSV-VZV reactivation. Next slide. So, we do think that it's a holistic approach, what we can do to protect our patients from the environment, what we can do to really boost their immune system from within. So simple measures to prevent the infection burden that is so high for our multiple myeloma patients, whether it is in the CAR T setting, whether it is in the relapse refractory other therapy setting. bispecific, etc. So just some common tips, good personal hygiene. Hand hygiene is a big one. Covering yourself with mask when you're in crowds, especially during at-risk sort of situations, big crowds, and the respiratory viral season, which is about to start. So you guys should be monitoring. We are monitoring community spread of the viruses. It's different in different geographic area, and your local health department is always updating. So be aware what is circulating in the community. Immunizations are the backbone. We do it in the setting of post-CAR T specifically from very early on, starting 6 months, and we'll talk a little bit about it. And then the medications that we talked about. So what are the vaccines that we commonly recommend for all patients? CAR T, non-CAR T, some of these are just seasonal vaccines. RSV, depending on age, influenza for everybody, every season, COVID vaccine, depending where you are in your journey post-CAR T, and other. So obviously it's a booster recommendation right now with the new one if you haven't already, and do speak to your provider where you are in your journey so they can tell you when it's the right time to get which vaccine. Pneumococcal vaccine, as you know, pneumococcal respiratory diseases are a big burden. So making sure if you're on maintenance every 5 years, you get the pneumococcal vaccine. If you're post-CAR T, you're going to get a whole series. If you're in bispecific, they will update you according where you are based on your previous vaccine. And then the zoster vaccine as well. So this is sort of speaks to a little bit about how we think about bispecifics as well. Similar to CAR T therapy, if you look at compare bispecifics, there's a paper that we did and we looked at our patients internally at MSK, and we found that the risk of infection could be higher on bispecific therapy when we compare to CAR T. And the reason is that because bispecific is an ongoing treatment. So the immunosuppression caused by BCMA target or other target, whatever targeted therapies are we getting, GPRCs, etc., that is continued. So the risk is ongoing, not inherently from the disease, but because of the ongoing treatment. So we do put everybody on valacyclovir or acyclovir and then PJP prophylaxis. The rest depends if somebody is experiencing neutropenia, they may go on levofloxacin. And then the big thing that comes is the immunoglobulin replacement therapy. If you look at your IgG numbers that is provided to you, you will see patients specifically on bispecifics that their number are going to be very, very low, less than, less than, less than. So that is a theme that is seen. And if you are especially experiencing infections in that setting, your provider or talk to your provider, they may put you on immunoglobulin replacement therapy to decrease that infection risk. It's not for everybody who receives it, but especially as a selected group of people who are experiencing recurrent infection. At times, the numbers do not need to be this low, but if you are still experiencing infection, you may be placed on immunoglobulin replacement therapy, irrespective of what the numbers look like. It all depends your experience, where you are, what kind of infections that you're experiencing. Next slide. So, as you know, we touched upon these toxicities associated with CAR T and the bacterial infection. So it's important to have a holistic approach, meaning, what other complications patients can be experiencing, making sure diabetes is well controlled, making sure we're monitoring the kidney function, looking at blood counts, what they're looking, and it is peeled off gradually, the prophylaxis, depending on where you are and as the time passes. But it is obviously as a journey, and everybody's journey is going to look different from the other person. Next slide, please. So this is just the CAR T guidelines that we put forth for post-CAR T. And as you know, that a lot of revaccinations are redone, not all of them. The vaccinations of choice are going to be the respiratory viruses, the 3 that we discussed, pneumococcal, diphtheria, and pertussis. These are all respiratory infections. hepatitis A and B, depending on risk most often, and then Shingrix. These are the high that's where the immunity wanes after CAR T for these particular pathogens. Next slide, please. It is our schema. I just wanted to put out there. I'm not going to go through the details of it, but just we start vaccine at 6 months post CAR T, sometimes as early as 3 months, depending on the situation. And some people would have preserved immunity. We don't need to vaccinate them. If they do not have preserved immunity, then they would be offered the vaccines. Next slide. So I think the big question, and I would love Beth to join in, for how do we get ready for fall? I know that this is going to be a discussion with your provider, where you are, what your risks are, who is living in your house, what is it that you like to do, how active you are in the community. So Beth, I'm just going to have you comment, and I'm happy to chime in.
Yeah, absolutely. And I think that this is just so timely. And I think fall is where we start to see these, but especially in myeloma patients with altered immunity, we used to see more of an October, November is where you're at risk for certain types of viruses and infections. But now that can really linger, especially in the northern states. I live in Cleveland, Ohio, and I can see these linger into May and June sometimes. And Dr. Shahid is in New York, and that might be different than those that live in Southern California or other parts of the country or the world, especially. And we might have people from Australia joining us, and our summer is different from their summer. So again, discuss your recommendations with your provider. And if they don't know, it's okay to say, is there an infectious disease specialist I can talk to? Because we have a wonderful group at my institution, and there are many around the country that feel very comfortable and confident making recommendations. Our infectious disease specialist, much like Dr. Shahid, will print out tables and recommendations for tailoring those immunizations and vaccines, not only with bispecifics or with CAR T. I'm still recommending everybody get the seasonal inactivated influenza vaccine. There are some centers and some individuals of older age, and I'd like to ask Dr. Shahid, if you have an individual that's 75 with myeloma, do you recommend just one flu vaccine, or do you recommend 2 vaccines? Because I get that question all the time. And what is the timing that you recommend?
So that's a very interesting topic. But what is interesting over the years, what has happened is that there used to be a high dose and low dose vaccine. Now, depending on what your institution is having on formulary, if it is a high dose vaccine, we recommend one shot at this point. But for the post-transplant setting and post-CAR T setting, it can be variable. So it just depends what formulary you have. There is a quadruple, like 4 sort of strains, and then the dosing of the antigen. So I would just speak to the provider, what do they have? And so we are currently at our institution just doing 1 shot.
Yes, and that's what we do as well. We have the high dose for those individuals over age of 65 that we'll recommend for those people. And even some of the ones that are a little younger that we see have frequent infections, IgG levels are 200 despite replacement. I think that's where we land. What are some of the resources? I know myeloma.org has quite a few resources, and I think it's a difficult discussion. You and I had briefly discussed it in this current climate of what are the right vaccines, what are the right immunizations, and it's difficult. How do you respond to your patients, Dr. Shahid, when they say, I don't feel comfortable getting the COVID vaccine, or I don't feel comfortable getting all these vaccines on one day? I hear that all the time. Do you want me to get 5 on one day? So how do you respond to your patients?
I think a tailored approach is the best approach. Some people are comfortable getting all vaccines one day. We do allow intervals. Some people have say they may be hesitant because they are aware or have read about side effects. We tailor them based on what they're comfortable with and continue the conversation. And I think also having that trust with your provider and making sure that people around you are also vaccinated. I think that I believe that what vaccines do is really lower the severity of illness for many of our patients. And we like to meet patients where they are in their journey for vaccines and other antivirals and IVIG, and it's a conversation. to be able to address many of the sort of confusion that is out there, some of the misinformation, and some of the true concerns that are out there. And so I believe even everything is, comes with a little bit localized reaction. So it's a conversation, and we are open to it.
Absolutely. So now we get to the fun part. We have so many questions that have come in from online. We're going to do our best over the next 15 minutes to answer as many as you can. As many as we can. I'm going to put on my reading glasses so I can read the small font. So bear with me here. It looked a little funny. So I'm going to keep too much of the detail. So some of these have quite a few details. I don't want to do personal details. We can't get consultations, but I'm going to speak in general to your questions and hopefully answer them still. Dr. Shahid, there is an individual who had a stem cell transplant in 2022, has been on Revlimid for 2 years. Their myeloma is in okay remission. They work in a hospital. Their neutrophils are around 0.75 to 1.27. Do they need to wear a mask? And what would you recommend when they have a kind of a lowered immune system, not quite in a great remission right now?
So I think if they're especially interacting with patients, we mask for all our patients. And I do believe that that's where they are. They're right in the flat area, the peaks that we talked about, where their infection is probably low, but exposure is at risk, and preventing yourself exposure, especially in a hospital care setting, or, I would do it masking and trying to stay up to date on your vaccination, the seasonal one would be the best strategy. I mean, obviously they're outside in the out environment where there's open, no crowding, that's a different story. But within the hospital setting, we would be recommending masking for such a situation.
Right. So there was an interesting question. This individual is getting IVIG every 4 weeks, and the bispecific antibody is every 4 weeks as well. They're asking if we should stagger them. And I always go back to the antigen and antibody kind of reaction. So you have an antigenic stimulation and then an antibody formation to protect you. And some of our treatments, such as the daratumumab, isatuximab, some of the bispecifics can also interfere with that. Dr. Shahid, do you have any insights as to whether or not we should stagger those? Because I like to just do it all in one treatment, but is there evidence that you know of that says we should split out the IVIG one day and then 2 weeks later or so do the teclistamab or whatever their treatment bispecific is?
So certainly, and that's a very valid question. The truth is that we also try to give him on the same day, and the reason being is the mechanism of action. The bispecific is a T cell sort of modulator, whereas immunoglobulin is passive immunity. So we do not believe, from a scientific perspective, that there is an interaction or perhaps the activity of the immunoglobulin or the bispecific has any interference. So we do recommend it so that folks can come in, get their thing, and then just, have, more quality of life and less time spent. But if there is any additional data that comes out, I will be looking for it, but there's none right now.
Absolutely. So another individual asked, there are a couple questions I'm trying to lump together. Is there a better time to have a COVID vaccine or a flu vaccine when you're on a bispecific treatment regularly?
And this is such a good question, and the question that needs more research. How do we respond to vaccines while they're on bispecific? We know that from more recent studies, from COVID studies, that there is a B cell component, which is hampered by the bispecific, but also there's a T cell component, which is less hampered by the bispecific. So how much do we get a T cell response or a B cell response? The data is out there. How we are recommending is just to get the seasonal vaccine. And if you can, somewhere between your shots can get it, that's great. That is just, you could say, hypothetical sort of frequency or separation. But I think that there is more research needs to be done, and there's such a knowledge gap there.
Great. It's so valuable to have you here. So thank you for being here. Another question that I'm lumping with another one is the idea of, we're told for many, like many years, antibiotic resistance. So if you can't just give an antibiotic for a sinus infection, you can get resistant, or your gut bacteria might not behave well. We're recommending PJP prophylaxis with Bactrim regularly, or some patients are on long-term levofloxacin or that fluoroquinolone class of drugs because they have neutropenia and we worry about infection. Are we causing resistant bacteria for these patients?
I would say that Bactrim is a different class of antibiotics, and it does not cause that much disruption from a microbiome perspective. And what we are aiming is a fungal infection, interestingly, the PJP. So it is not supposed, and it causes the bacteria targets generally the antibacterial activity of it doesn't interfere with resistance per se, because we're looking at if a gram negative, the GI flora becomes resistant to Bactrim, we have many more options. Quinolones are very interesting, and that's why we try to decrease the exposure as much as possible, but it's always risk versus benefit. We do know that the quinolones decrease the risk of bacteremias in the neutropenic setting. So definitely each day, each time we see somebody on Levaquin, I ask, can I stop this today? And that's what the conversation you need to have each time. But definitely there is an inherent risk of resistance and disruption of microbiome as well. Yeah.
Excellent response. That was wonderful. Thank you so much. The couple questions about stem cell transplant and prevention there. One of the respondents said that they weren't put on Bactrim yet for the transplant. We don't give Bactrim for transplant. The Bactrim is for CAR T cell therapy and the bispecific antibodies. So most often you'll just be on acyclovir prevention for the shingles or the herpes types of viruses. So your doctor is fine. And so if you ever have any concerns after this, remember to go back and talk with your provider or your doctor about these. Please share your thoughts on post-CAR T patients to avoid infections besides wearing masks, washing hands, and IVIG infusion. And I think this question was before we went through all of the detailed immunization recommendations. Are there newer forms of specialized immunoglobulins? So some states and hospitals have sub-Q IG, and then we have IVIG. Do you feel comfortable sharing the difference between the sub-Q IG or the IVIG, and is there a difference?
So from a mechanism perspective, the difference really is the mode of delivery and ease of time spent in an infusion center. They're both products derived from the same source, and however, one is given at home because, especially for example, in the primary immunodeficiency setting where kids are home, they need to get things, or people with different immune deficiencies, they just do it at home. Otherwise, IVIG is given in an infusion center because it can have transfusion reactions more so. It's not geared towards at-home administration. Mechanistically, it shouldn't be. There is plenty of data, how often you need to give for each, what doses to give for each. So I do think that in sort of their effect, they should be equal.
Great. And there are so many wonderful questions, and we only have about 12 more minutes in the program and about 8 more minutes to talk through them. So I'll hurry up. So if a person has no M-spike, the lab tests are good, are they still at risk for infections as the same person with active myeloma? And I would say that we went through the host factors. So if you don't have diabetes or hypertension and kidney disease and you're in a good remission, that's where you should have your unregulated maintenance. Their lowest risk for infections as long as you're not developing neutropenia. So still wash your hands, avoid people with colds, stay up to date on your immunizations, and enjoy your life as best as you can. Does the vaccine for pneumonia reduce the risk of infection? And it should reduce the risk of pneumococcal infections, correct, Dr. Shahid?
Yes, most definitely. The pneumococcal disease used to be very invasive because of the vaccine and herd immunity. The burden of pneumococcal in the last 2 decades have really decreased. multiple myeloma patients are so unique to have deep invasive pneumococcal infection. That's why I'm a big sort of proponent, like, we got to get the pneumococcal vaccine in so we can prevent invasive disease. So, yes.
Absolutely. So another important few questions we had in here was about low IgG levels on patients that aren't receiving CAR T and are not receiving bispecific antibodies. The questions pretty much were, I have a low IgG level, but I am not on IVIG, and should I be, and at what level should you be on? I will answer that question briefly and hear from Dr. Shahid, but again, there's functional immunoglobulin, and then there's this dysfunctional, whatever you have left is still not working. So we do a test called immunoglobulin subclasses sometimes for people that are getting recurrent infections and their IgG levels are a little low in order to justify, and for insurance purposes, sometimes you need to do that. But sometimes you have a functional hypogammaglobulinemia, low immune system, and sometimes they're dysfunctional IgG cells. And so I will have people that have very low IgG levels on like daratumumab maintenance. They're like 200, 300, 100 sometimes. They never get any infections. They feel great. And it's just so different from the people with CAR T and bispecifics because you get that dysfunctional whatever is low there. What are your thoughts on when people, Dr. Shahid, should start IVIG therapy? And are there any clear recommendations? Because there aren't any that I know of, but this is your area of specialty. So maybe you know something I don't.
I think that's a great question. And you almost, you answered in the sense, what's happening to a patient? We're not going to treat a number. We're going to treat our patient. And if they're experiencing recurrent sinopulmonary infection, then there may be benefit for giving immunoglobulin therapy. Remember, IVIG is meant to decrease sinopulmonary infection. It does not decrease other risk of infections. So there is another inherent risk of infection, which is not prevented by immunoglobulin therapy. So we want to keep that in mind. What infections are they experiencing? And if these are recurrent sinopulmonary infections, then we place them immunoglobulin therapy. And if their IgG level is 250, like you said, 300, and they haven't had an infection in a year, I'm not sure if there's any reason to be given unless we start to experience some infections. In the outside of IgG post-CAR T settings, I'm talking about the maintenance sort of phase.
Yeah, absolutely. So we had a couple questions about how often should an RSV vaccine be given, and then also live versus dead vaccines, MMR. We hear about these all the time. So is there a worry about myeloma patients to get an MMR vaccine, and how often should we get RSV, somebody that's not transplant, not cellular therapy?
So current guidance for RSV has been just one shot, and there's some durability data, but there hasn't been a follow-up data that is shared in the immunocompromised setting. When is the most appropriate time to give the RSV vaccine? So at our institution right now, we're not repeating the RSV vaccine outside of post-transplant and post-CAR T. So that's one thing. And the other thing, and that's also by age, not everybody post-CAR T or post-autologous stem cell transplant is getting the RSV vaccine. And the other thing about the MMR vaccine, we're getting this question and a lot of concern, rightfully so, from our patient, that because they're worried they can have an unknown measles exposure. We're definitely in the process of putting forth guidelines with American Society of Hematology, like, for our patients, for providers, what to do. But if you are immunocompromised, there is some data regarding giving MMR on bortezomib and some sort of other maintenance therapy. But outside of that, for bispecific, post-CAR T, or upfront quadruple therapy, we're not recommending that MMR, because it's a live vaccine and there are adverse events associated with MMR vaccine, which we know. So it is your net state of immune suppression, and talk to your provider about where you are in that net state of immune suppression and if it is safe for you to get it.
Absolutely. We have time for one more question, and it breaks my heart because there are so many in the chat. And yes, you will be able to access this presentation. It'll be online, share it at your support group, share it with your friends and your friends' friends. would you have an increased risk for infection if you have low platelets and other low blood counts? My answer is not necessarily, but it might speak to the overall health of your immune system, the overall health of your body's function. Because remember, it's only the blood counts are little pieces, parts. There's all host factors, there's disease factors, et cetera. So yes, you might have bone marrow suppression, might put you at a little bit of an increased risk, but it's not necessarily 100%. So Dr. Shahid, would you agree with that before we go to our outro? And I see Robin was just checking her clicker to make sure it was working. So she's ready for us to close out in a moment too.
Yeah, I agree, Beth, 100%. It's a whole, not just one number that we look at, for sure.
And I love how you say we treat people, not numbers. I've been saying that for years. The numbers will give us insights as to what to test, what to investigate, and what to do next. But it's definitely discussion. So my goodness, this is just such an honor to present with you tonight, Dr. Shahid. You did an amazing job providing an overview of vaccines and health and how patients can protect themselves for infections. So thank you so much for donating your time, and you're so busy. We appreciate you so much.
Pleasure is all mine. Thank you so much for having me.
And Robin, you'll take us out.
Sure. And Beth, that expression that you just gave goes to both of you. You're amazing people that are doing such good things. And I love hearing the individualized, specialized approach of how important it is for us to hear from our care team, our specialists, and where is your myeloma at, basically, to make sure that your immune system, if if it's strong or if it's not, and then what those best practices could be, or the discussions, right? That shared decision making, right, Beth? When you talk with your healthcare providers, hey, I just learned about this. How does that apply to me? So as the key takeaways, I think you all talked about all of this, and thank you so much for the refresher on immunizations. And so now we're just really gonna close it out and remind everybody, as Beth just did, that the replay for this will be available. I know sometimes I listen to these a couple of times just to jot all my notes down and be able to talk about it with others. And just the reminder, as we close out today, that feedback survey will pop up. If you can please take that, or if you can respond to the email that you'll be receiving. We do really take your input into consideration for everything that we do. And of course, thank you to our sponsors, and thank you to each of you for spending the time with us tonight to educate and empower yourselves. And we thank again Dr. Faiman, Dr. Shahid. This was really wonderful, helpful information, especially as we go into the season here in the United States. And as Beth, you said, maybe it's different wherever you're tuning in from. So wherever that is, we wish you all well, and thank you so much. Have a wonderful rest of your evening.